Commerce and Consumer Protection will come to order. For the record, today is March 20th, 2019, and a quorum is present. Members, today we have one bill on the agenda, Senate File 278, a bill dealing with pharmacy benefit managers. Senator Utke, would you like to move Senator Jensen's bill before the committee?
Thank you, Mr. Chair. Yes, I would like to move that bill.
Thank you, Senator Utke. Senator Jensen, I believe you also have an amendment, the A13 amendment. Senator Utke, would you please move the A13 amendment?
Mr. Chair, I'll move the A13 amendment.
Senator Jensen, would you go ahead and explain the A13 amendment?
Thank you, Mr. Chair. The A13 amendment goes on to define specialty pharmacy, and that's a big thing. It also identifies what fees will be collected in order for this work to be done, placing it at $8,500. It goes on to discuss how to create a level playing field so that if the PBM owns a pharmacy or owns a part of an interest in a pharmacy, how can we be certain that retail network pharmacists are able to match price and compete? And that's in lines 2.8 to 2.29. It nails down the appropriation, and that's about what the amendment does. If you would like me to take some time, Mr. Chair, to briefly go over the Senate File 278, I'd be glad to do that as well.
We'll move the amendment first. Members, any questions for Senator Jensen on the A13 amendment? Seeing none, all those in favor of the A13 amendment signify by saying aye. Aye. Opposed, nay. The amendment carries. Senator Jensen, to your bill.
Thank you, Mr. Chair. And I would absolutely be remiss if I did not extend appreciation to my co-authors on this bill for Senate File 278, Senator Dames, Wickland, Draheim, and Benson. But I also would want to share with you that we have a very similar bill moving through the House, and it probably has one stop left. And I would like to thank Representatives Mann and Liebling and Morrison and Hamilton and Halverson and Dean and Cantrell and Munson and Grunhagen and Huot and Purcell and Baker and Lewick and New and Schultz and Muller and Brand and Poston.
Is this a roll call?
The level of broad-based support for this bill has been most appreciated by me, and it's gratifying. This bill creates new law. It licenses PBMs. It charges fees. It creates appropriate revenue stream to do the work it has to do. It creates definitions that haven't been created before. On a global view from 30,000 feet, it's trying to victimize no one, trying to throw no one under the bus, but say pharmacy benefit managers perform critical functions for plan sponsors. Plan sponsors are generally going to be your large employers through a self-funded program, or for your insurers, your major health plans. The bottom line is, in the late 60s, when pharmacy benefit managers were first created, their biggest function was to process prescriptions. But through the years, they've been asked to do more and more. They create formularies. They look at scientific evidence as to which drugs should be on the formulary. They analyze cost. They look at options. They talk to manufacturers. They address issues with specialty biologics in terms of who can provide the services we need, the distribution requirements, whether there's specific requirements. And through the years, PBMs have become an integral part of the supply chain. But clearly, the supply chain generally would be thought to go from the manufacturer to the wholesaler and then to the retail pharmacist. And so I do think that the PBM is a little bit of an insert. And so now we're at a point in time where we say, we need to shine a bright light on this and make sure that the business practices work to create a level playing field, and also to create a level of transparency and always attend to the patient's needs, especially in regards to letting patients know what they would benefit from or not. Moving on, this bill will license pharmacy benefit managers. There will be licensing fees. It addresses general business practices. Initially, we did have a fiduciary responsibility within the context of the original bill, and that has been removed. We're dealing now with other language such as fair dealing. There's a fair amount of transparency language present. We address network adequacy. We talk about specialty pharmacy services. We also talk about therapeutic alternative prescription drugs. We talk about maximum allowable cost pricing. We address pharmacy audits. We talk about mail order services and mail order pharmacies that are owned by PBMs. We go on to discuss synchronization, allowing patients to synchronize their medications at least once a year at no cost to them or to the pharmacist, so that if they're getting some of their meds on the 15th of the month and some on the 25th and some on the 10th of the next month, they can synchronize. We're removing gag clauses so that we're opening the door for patients to get good, solid information from the pharmacist at the time of receiving the drugs. And we have point of sale information in there as well. And then we also have coverage by substitution, allowing pharmacists to work to the top of their license in certain situations. If a physician is not available and for whatever reason a medication is not on a formulary, if there's a bioequivalent similar drug, that can be substituted and the physician would have to be notified. That, Mr. Chair, is a summary of the bill. I do have a couple of testifiers.
Thank you, Senator Jensen. And if Ms. Earhart would please come forward, and Mr. Stephen Schondelmeyer, if you'd both please come forward. Welcome to the Senate Commerce Committee, and please state your name for the record and proceed with your testimony.
All right. Good morning, members of the committee and Mr. Chair. My name is Jessica Astrup Arrett, and I'm a third-generation owner of Astrup Companies. I'm also a pharmacist. Our family operates 17 retail pharmacies, 4 long-term care pharmacies, and a specialty infusion pharmacy in central and southern Minnesota. I serve as a board member and work as a staff pharmacist in our community or retail locations in Northfield and Faribault. Sterling was founded by my grandfather in 1952. He came to Austin, Minnesota from North Dakota with $11 in his pocket to open a Walgreens agency store. The first banker that he went to for a loan denied him. The second one liked him, gave him a chance, and allowed him to open his first store. After a ton of hustle, relationship building, and mentorship, my grandpa grew a successful business that remains a staple in our small town. My grandpa passed away in 2014, but he was always proud that the only loan he ever took was to open that first store. He was able to build his business by providing expertise to his patients, engaging with his community, and consistently offering a higher level of customer service. He went beyond the competition, and that made a difference. Times have changed. Our industry has become so complicated, and so with so many entities involved, including pharmacy benefit managers, which makes it increasingly difficult for our independent business to survive. We can earn new patients, take excellent care of them, and build trust only to be told that we cannot fill their prescriptions. We can provide hours of counseling to ensure proper medication use, and help patients navigate open enrollment for Medicare and commercial insurance plans. We can communicate with physicians and insurance companies, but we're not compensated for these services. We're forced to operate on narrower and narrower margins every year while providing more and more services. I thought it would be good to come armed with a few examples of how pharmacy benefit managers have made it more difficult for my patients to receive the care that they need at a cost that they can afford. PBMs have made it increasingly difficult year over year for our family to operate our mostly rural community pharmacies. These are real patients with real consequences to their health. First, I was working with a patient who was having trouble affording his copays and therefore was not filling his medications on time. He was actually stretching his 30-day prescriptions to almost 60 days or taking his medications about every other day. We identified one generic medication in particular that was assigned a higher than necessary copay from his PBM. This was a $13 medication that had an assigned copay of $75. Unfortunately, my team was bound by gag clauses in our contract and were unable to tell him about the less expensive price that he could be paying there. This is one thing that's been addressed on federal level, but is also included in this bill here. So he was paying a $75 copay for a $13 drug. The pharmacy in the end made about $10 on that, and the PBM clawed back the additional $60 about 6 months after that claim was adjudicated. My second example, I have a patient with COPD who was established for a long time, years, on a brand name inhaler. An insurance change in January made her change to a newer, more expensive product, with a completely different inhalation device. The patient was scared because without this medication, she will end up in the emergency room, and this new device was so different from her previous that she wasn't sure that she would get the amount of drug that she needed. We provided necessary counseling, but I just still don't understand why the change was necessary when the original product was less expensive and it was working for the patient. I just often wonder why PBMs are making medical decisions for my patients whom they've never met, and why PBMs are favoring certain more expensive products over more cost-effective ones. Lastly, one of our pharmacies received a call from a PBM that we are all familiar with and was asked to reverse a claim for one of our regular patients because this PBM's mail-order pharmacy was attempting to fill the prescription. We called our patient to discuss, and she stated that she didn't send the prescription to them, she didn't even know who this pharmacy was or how they got the prescription, and she didn't want it filled there. The PBM had simply intercepted the claims data and tried to steer the prescription to themselves. We encounter this practice, sometimes called prescription trolling, time and time again because of the placement of PBMs in the transaction chain. If we can meet all the needs of the patient and provide the necessary data to the PBM, it seems like the PBM should allow us to continue to care for our patient. Patients are not one-size-fits-all, and neither are pharmacies. Some pharmacies offer a higher-touch service to meet the needs of the most complex patients. These services keep patients out of the hospital, and they position pharmacists to be valuable members of the patient's care team. Patients deserve a choice when it comes to pharmacies. I firmly believe that PBMs were started to do good and to contain costs. However, today that's not happening. They need scrutiny and visibility to ensure that claims processing industry has fair rules of the road, and most importantly, to ensure that patient care is the primary focus. Thank you so much for the opportunity to speak today. Let me know if you have any questions.
Yes, thank you, Chair. My name is Steve Schondelmeyer. I'm here as an individual, although my job is as a professor at the University of Minnesota, where I study pharmaceutical economics, and I've studied this pharmaceutical marketplace for about 45 years now in detail. Studied all levels of the market: manufacturers, wholesalers, retailers, PBMs, insurance companies, plan sponsors, consumers, and patients. And I'll just briefly state my views on this and would welcome questions as we go down the line. PBMs play an important role in the marketplace. They are important, they're necessary. But PBMs have gotten to a point where there are only 3 that control like 75 or 80% of the market. And when you compare that to the size of the plan sponsors they contract with, we're a fairly large, at the University of Minnesota, we contract with a PBM and we value their services. And we only have 40,000 covered lives. We're fairly large in the state of Minnesota, but we're tiny compared to the size of the PBMs that we interact with. So there's an imbalance in the market in terms of who plan sponsors contract with and who PBMs contract with. The PBMs will tell you that we don't do anything that the plan sponsor doesn't ask for. Arguably that's true, but the leverage isn't there for plan sponsors to get all of the details they want. I have worked with many plan sponsors who have asked for PBMs to either serve in a fiduciary role or serve in a fiduciary-like role or assure them that they would act in the best interest of their plan. And the PBMs often refuse to do that. And some say, well, we'll do that as long as we can define what that means and define the terms. Over time, and in recent years, we've seen a number of behaviors emerge in the PBM industry that are signals of them taking advantage of their position in the market, like my colleague has just described with her own pharmacy. I've seen this across many pharmacies and across many plan sponsors. I've seen PBMs that add a price on to the generic, and keep in mind the PBM doesn't buy the drug, they don't take possession of the drug, they don't have it on their property. They buy it from the community pharmacy and just pay for the transaction. And then they add a cost onto the generic prescriptions. And with generic markups, it's increased the cost of generics, which generics have been a great tool to help us save money in the healthcare marketplace over the last 2 or 3 decades. But some of that savings now has been eaten away by PBMs adding on these markups. And then they'll turn around. So they'll pay the pharmacy $25 for a prescription. They'll turn around and bill the plan sponsor $40 for that prescription. And sometimes they don't even tell the plan sponsor that they're going to do that. The PBMs also have ways of influencing generic prices called MAC prices. And originally in the market, MAC prices were kind of one MAC list across the whole market. Now most PBMs have multiple maximum allowable costs, and they apply them in different ways. Also, PBMs arrange for networks of pharmacies and try to steer patients to certain places to get their health care. And sometimes that can be good if it really helps us save costs. And one would assume that if you go to a preferred network pharmacy, that as a plan sponsor, you would assume that your patients would be getting a better price and you as a plan sponsor would get a better price. Sometimes that happens, but I can tell you I've seen in the Minnesota market with a number of PBMs that do business in this market where it actually costs you more as a plan sponsor for the prescription at the preferred pharmacy rather than less. But they don't bother to tell you that and give you evidence of that. So there are a number of behaviors that have begun to emerge based on the size of the PBMs, based on their ability to kind of keep the information cloaked and hidden, and to play with definitions and contracts, to play with implementation rules. So we're not here to say, let's get rid of PBMs. We're not here to say PBMs shouldn't be profitable. They should be. But let's make PBMs and their business models transparent. Let's have a process of oversight. And let's come up with some metrics. For example, in Minnesota and in most states, we have an insurance commissioner who regulates and provides oversight to health insurance plans. And one of the concepts for health insurance is a medical loss ratio. In other words, the insurance commissioner wants to make sure that at least a substantial portion of the money that's collected goes to providing health benefits to the people insured. I think we need to come up with a similar concept from the PBM world to say PBMs need some administrative costs, but there should be a limit on that. And here are the range of administrative ways that they can collect revenue from a plan sponsor. And let's eliminate some of the ways they collect revenue that are what I call reverse perverse economics. The current model is set up so if the PBM and the drug company keep raising the price, they can give you a bigger discount every year and a bigger rebate every year. It also costs you more every year as a plan sponsor. You know, you tell me how much rebate you want, and I'll tell you what your price is. That's kind of the way the market works these days, and that's not healthy. It's not helping us use our resources wisely in healthcare, and so we need a marketplace that is using marketplace behaviors and economic efficiency rather than ways to extract revenue from the healthcare market, where we have a lot of need. We have a lot of unmet need in Minnesota, and even most plan sponsors have unmet need, and we need to use our resources wisely. So with that, I will thank you for your time and would welcome questions.
Senator Sparks.
Thank you very much, Mr. Chairman. And Senator Jensen, thank you for bringing this bill forward. You know, I was honored when you asked me to be a member of your Healthcare Access and Affordability Committee. And I know you've done a lot of work on this bill and in other areas as well, and I thank you for that. Ms. Astrup Earhart, I also want to thank you for coming today and testifying. I don't need to tell you this, but you had a great grandfather. We're very grateful for all that you have done in Austin and continue to do in Austin. And I don't mean to put you on the spot. I know it was a very difficult decision. But can you tell us a little bit about what happened to the pharmacy in Albert Lea? And I think for members to really understand, in these small communities, there's a real relationship that happens between the pharmacist and the customers. You know, you go there and you've known these people for many years. They know you by your name. And I know it was a tough decision, but can you speak just a little bit to what happened in Albert Lea and the pharmacy that had been there for many, many years as well?
Ms. Astrup Earhart.
Absolutely, Mr. Chair and Senator. Thank you for your nice comments. Yeah, we were in Albert Lea, the Albert Lea community since the 1960s, so we were there a long time and had to make the difficult decision a year ago, or this past year, to close that location. And there's a variety of factors that go into that, but when you have in rural communities very few employers that are contributing to your pharmacy, so we have in communities like Austin, Hormel obviously is a very dominant large employer. If the PBM that they're working with is not favorable for an independent pharmacy, that one decision by that employer, which they don't always understand or have other options, I should say, but in the case of Albert Lea, the Mayo Clinic plan is a big driver. They're a large employer there, and we were having such a difficult time with margin, with patient access to our pharmacy, that year over year we just continued to have patients come in on January 1, and we could no longer fill their prescriptions. They were now required to go to a larger player down the street, or even worse than that is having to go to the mail as their primary option. I don't believe that Albert Lee has a CVS, and I know that there's a couple large employers in that area that require CVS as their preferred pharmacy, which allows people mail order as their primary option, which is really challenging in a rural community. So we continued to see these large employers have to make difficult decisions to manage their healthcare costs, and unfortunately that made it so that people were no longer able to use our pharmacy despite their wishes and wants. Does that answer your question, Senator Sparks?
Senator Hayden. Senator Hayden is the question for the testifiers, because I'd like to make sure we get through all the testifiers. So if it's for the testifiers,
It is
feel
for the
free to-
testifiers.
Feel
Thank
free
you.
to go forward.
Hopefully Senator Jensen, our professor, can answer. So I'm always, as we try to figure this out, try to wrap your arms around this whole issue around rebates and how rebates work. And it isn't necessarily point of sale rebates, right? Like the customer doesn't get the rebate, because that's what people think, right? Like you get a coupon, you go to the grocery store and you get a certain amount of dollars off of your product. We're talking about something much different here, and rebates from the manufacturers of the drugs to the PBMs, and they interplay there, and the consumer is kind of a little outside of that. Can you explain how that works just a little bit more, and why a manufacturer would just not say, you know what, we're just not going to play with you. We're just going to go directly to the pharmacy and sell our drug there. Help us understand how that works.
Mr. Schandelmeyer.
Thank you, Mr. Chair, and thank you, Senator, for that. A very good question. I'll do my best to answer it simply, but it's not a simple market. In general, and I've been around, as I said, this market for 45 years. Back in the 1980s, we had some therapeutic categories where there were certain drugs that were competing. Like I remember the H2 antagonists are drugs you would take for a bad pizza. Basically, it was for Zantac and Tagamet would be drugs you might recognize. Actually, they're available over the counter now, but they used to be prescription only. And as far as therapeutic categories, those drugs were fairly interchangeable. You could use Tagamet or Zantac. They essentially did the same thing. And so some large employers and or PBMs went to the manufacturers and said, look, we could put Tagamet on our formulary and shut Zantac out. We could put Zantac on our formulary and shut Tagamet out. How much will you give me back as a rebate to favor your product, either favor your product or exclusively use your product? And so they got, 5 and 10% rebates back at the margins. They got some rebate back. And at first, the PBMs kept that as money they got for negotiating it, and it wasn't necessarily passed on to the plan sponsors. Also, the Medicaid program saw that the private market was doing this kind of rebate, and 4 or 5 state Medicaid programs went to the same manufacturers and said, we'd like to negotiate rebates also. And those manufacturers said, nope, we're not dealing with government programs. Well, that upset some members of Congress so much that they passed the Medicaid rebate law. And you might be aware that our Medicaid program in Minnesota and every other state has rebates that are mandated because of that reaction. Fast forward, though, over the years, manufacturers and PBMs write contracts, and it's between the manufacturer and the PBM. The plan sponsor doesn't typically see the contract, doesn't know the terms, doesn't know the amount of rebate on a specific drug. They're just told, we're getting you a better deal, so we're going to prefer this drug, and we'll pay you some money back as a rebate. Well, what they figured out is they can create this system where if the manufacturer keeps raising the price, say 10% this year, they can give you 5% more rebate next year, 5% more dollars. They can give you a bigger discount, and they still collect more money. And what they don't tell you, what the PBM and the drug company don't tell you is it's going to cost you as an employer more to get more rebates. the times when I've evaluated PBM contracts, the ones with the highest dollars of rebate being paid out and the highest % discount actually cost the most because they're collecting money up front to then give you some back after the fact. Let me also explain, what does a rebate really mean? It means the patient and plan sponsor overpay for the drug up front when it's dispensed by 10 to 50%, overpay, and then the PBM and drug company collect the money and they sit on it for 9 months, and then they send you back part of it with interest-free. Don't pay you for the interest and time value of your money. So they overcharge, they keep it for 6 to 9 months, and then they send it back to you later. And they won't tell you which specific drugs it was for. They just give you these aggregate lump sums. And you notice they even wanted aggregate rebate amounts in this bill. That really masks what's going on. Consumers, physicians, pharmacists, plan sponsors can't make wise decisions if we don't have good cost information. So if we keep hiding it with aggregates and things that are hidden in proprietary contracts, we will never be making good decisions with our healthcare dollars, and we'll overspend and we'll keep paying them too much up front, waiting 6 months for interest-free loans. It's not a good system.
Senator Hayden, follow up? Thank you. Members, any other questions for the testifiers? If none, do stay close because we may have some a little later. If Bentley Graves and David Root, if you could come forward, please.
Thank you.
Morning, folks, and welcome to the Senate Commerce Committee. Please state your name and go forward with your testimony, starting with Mr. Graves.
Thank you, Mr. Chair and members. My name is Bentley Graves with the Minnesota Chamber of Commerce. I appreciate the opportunity to testify today, and I appreciate Senator Jensen's work on this issue, and especially in bringing forward the 813. So Senator Jensen, along with the testifiers, have made significant mention of the tension that exists around this issue and within the kind of the supply chain for prescription drugs. That tension being between cost savings for patients and plan sponsors and employers, as well as some sort of level playing field for pharmacists, local pharmacists, community pharmacists, and empowerment for patients, access to patients. And I do believe that in bringing this bill forward initially, Senator Jensen had tried hard to strike that balance in some of the things that he was trying to do. Nevertheless, we had concerns about a couple of pieces of the bill. But Senator Jensen, through the last couple months, has been very good about sitting down with us and taking our concerns, working this through, trying to find a way forward to strike a better balance to meet those needs without triggering some of the very serious concerns we had with the original version of the bill on the cost side. And so I very much appreciate the work that's been done in the 813 amendment and the work we've been able to do with Senator Jensen, some of the proponents of the bill. What's reflected in the 813 amendment does address the concerns that we have raised and have had with earlier versions of the bill. And so, certainly look forward to more discussion about this larger issue and the impact that it has on employers and their ability to provide cost-effective healthcare benefits to their employees. This bill does a lot of other things outside of the sections that we had worked on. I suspect that Mr. Root may have some things to say about that, but things like gag clauses and synchronization and substitution all move the needle in the direction of greater transparency and a more level playing field, along with the work done in this amendment. So, very much appreciate the opportunity to have worked on this with Senator Jensen, and I'm happy to answer any questions you may have. Thank you.
Thank you, Mr. Graves and Mr. Root. If you would please state your name and go forward with your testimony.
Thank you, Mr. Chairman, members of the committee. My name is David Root. I am a representative of Prime Therapeutics. We are a PBM, and in fact, we are the PBM for Minnesota Blue. Prime Therapeutics is a unique PBM in that we are owned by 18 not-for-profit Blue Cross Blue Shield plans, Minnesota Blue being one of those. I'd like to echo Bentley's comments with respect to Senator Jensen and the ability that we've had to work with him, can continue to work with him. There are still, as we articulated this morning in a meeting with him, a couple of sections that we still need to work through. We think the bill is working towards striking a reasonable balance between protections for community pharmacies vis-a-vis a level playing field and the ability of plan sponsors to best maximize their healthcare dollar and their healthcare spend for citizens in the state of Minnesota. I think it's fair to characterize the fact that we feel very comfortable in the fact that Senator Jensen and other members of the stakeholders have agreed to continue to work with us to look at some of the other issues we have, specifically around Section 6 of the bill and a few other minor areas as well. So we look forward to continuing that dialogue, and we'll hopefully try to put a solid compromise forward prior to the floor. Thank you.
Thank you, Mr. Root. Members, any questions for Mr. Bentley or Mr. Graves or Mr. Root? Senator Hayden.
Well, thank you, Mr. Chair, and to our testifiers. I asked Senator Jensen, I asked this question in the HHS committee, and I don't know if you guys have expertise in there, but do we have PBMs in Canada?
Somebody would like to answer that?
Mr. Chairman.
Mr. Root.
Thank you. I know that I would assume the answer is yes. I know that some of the existing PBMs in the United States are developing relationships with Canadian pharmacies. It's a little different system there. They have the national healthcare system. So I'd need to investigate that, but it's highly possible that they have a state-organized, what we would call a state-run PBM. Yes.
Well, thank
Senator
you, Mr.
Hayden.
Chair. And the reason why I asked it is a little tongue-in-cheek. They pay so much less for prescriptions there. So I'm trying to figure out and get to the root of if they have PBMs there. I mean, do they have this rebate structure? Do they have all of this kind of inflated kind of cost? This what the professor said. This kind of rise and fall in these exclusive relationships that customers don't see the benefit of, but the PBMs and but the PBMs do. So I'm trying to figure out what the relationship, if they have them there, and what their relationship is, because it seems to me, Senator Jensen, that you could just cross the border and get the same medication so much cheaper.
Senator Jensen.
Thank you, Mr. Chair, and thank you, Senator Hayden. I would agree with Mr. Root. Basically, the PBM as a concept in the United States would be substantially different in Canada, in part because Canada takes in this nationalized drug program approach, they actually have a commission that provides an opportunity for all the stakeholders to come and present information, especially in regards to manufacturers. So if they're going to come out with a new drug, ABC, and they're going to charge $500,000 a year for it, they will be asked to demonstrate the information that's necessary to evaluate whether or not that's a reasonable price. What was the cost of R&D? What's the cost of actually producing it? What's the cost of the ingredients? What's the cost of distributing? Is it a specialty large molecule drug, or is it a small molecule that's more easily reproduced? Those kinds of things will be done by this commission. In the United States, PBMs do a lot of that work. Frankly, one of my goals in this bill is to make certain that we're not throwing anybody under the bus. We talk about a lot of things here in the legislature, and some of them are critical tools for the PBMs to do their work. When we talk about step care, when we talk about prior authorizations, these are tools that if we don't allow PBMs to use them to keep pushing the cost of medications down, it's going to explode. Fact of the matter is, over the last 20 years, we've reduced inpatient costs of the healthcare pie from 34% down to 17%. But while we've cut it in half, the cost of our medications in our country has more than doubled. So there's a balance to be struck, but the Canadian system is substantially different than ours.
Senator Hayden, follow up. Senator Limmer.
Thank you, Mr. Chair. Senator Jensen, I missed part of your presentation. I was busy outside the room here, but does your bill do anything to help streamline the flow of specialty drugs to patients? Would this do anything to benefit that phase of getting the appropriate pharmaceuticals to the patient in that relationship that a consumer has to go through to get it?
Senator Jensen.
Thank you, Mr. Chair, and thank you, Senator Limmer. In terms of streamlining specialty meds is a difficult concept. Some people refer to specialty meds in regards to price, maybe $500 a month or more. Others would talk about the size of the molecule. Is it a molecular or macro? And is it a biologic? Was it made in a lab with chemicals, or was it made with a living organism helping along the way? But if we're going to talk about specialty pharmacies that indeed address biologics, we're not actually streamlining as much in this bill. I don't think we're trying to intrude in that regard. What we're trying to do is make it more transparent and make it more clear that in order to do this kind of business, this is touchy business. I mean, you may have a product, take a vaccine. When it comes to my clinic, we have to know that nowhere along the supply chain did the temperature ever drop below X or go above Y. And it takes a fair amount of technical expertise to do that. So PBMs will take on the responsibility of making certain that those kinds of specialty drug needs are being met. Then we're trying to create an opportunity in a transparent world so that if there are these upstream rebates or downstream discounts, that they're demonstrating and being shown. And that's where some of I think some of the tension and dialogue have come into play. Mr. Chair, if you don't mind, I think Mr. Root could do a nice job of adding perhaps to my testimony.
Thank you, Senator Jensen. Mr. Root?
I think Senator Jensen is exactly correct. It's less of this bill, and the material that it addresses from its inception is less about streamlining the system, especially around specialty medications. I think the system around specialty medications through PBMs and health plans, specialty pharmacy networks, whether they're owned by specialty pharmacies or specialty actual network, in-network, independent specialty pharmacies, which are part of our network. I think they do a good job at dealing with their patients. These people are high-touch patients that require the kind of effort that you heard about previously from one of the testifiers. We provide those, PBMs provide those with their specialty pharmacy networks, and we expect the retail specialty pharmacies in our networks to provide that same service. That's what allows them to be a specialty pharmacy in our network.
Mr. Chair.
Senator Limmer.
Mr. Chair, I've had the experience just recently to take care of a family member that needed specialty drugs, and it was right at a point where we changed from one healthcare program to another at the beginning of the year. I would say the patients require high touch, but I don't, in my experience with two major companies and two major special pharmacies that deal with this classification of drugs, they have been anything but high touch. And we finally got the medication after a 2-month delay. And if there's anything that we can do, it just means to me that we've got a whole lot more work to do to oversee this as a government, to make sure that people who are in need of those specialty products get them at the earliest possible time. And especially when it takes 3 weeks of constant doctor prescriptions being sent to the specialty drug company, and the response when the drugs don't come at the scheduled time, that pharmacy doesn't know anything about the previous conversation. And I hear this from other people too. It's not just my experience. I hear it a lot. And people have to be on hold hours on end just to get to the first wave or two to get in the door and get that information. So if there's anything in the future we can do to help that classification of patient, I think it's ripe for reform.
Senator Jensen, any comments on that?
No, Mr. Chair.
Thank you, Senator Jensen. Members, before we move forward with any more questions, are there any other testifiers in the audience that would like to come forward? Seeing none, if the first two testifiers would like to join the testifiers and Senator Jensen at the table, we'll continue with questions, but that'll give an opportunity for everybody to be part of the conversation. So if the first two would like to please come forward. Senator Cran.
Thank you, Mr. Chair. And Senator Jensen, thank you for bringing the bill forward. I think it covers a lot of the necessary challenges that our citizens have in the healthcare system and as it relates to prescription drug costs. Part of the process is, of course, reporting through the Department of Commerce, and we're seeking, and the majority of it is really transparency. So citizens understand their abilities and their rights, and everybody, and even here today, pharmacies who can best serve because they have the closest relationship outside of the doctor. But the one thing I'm concerned with, and I want to make sure as we move forward, is transparency where it's required and privacy and proprietary information protected when necessary. So I have a healthy skepticism of our Department of Commerce on the Safe Flight issue. And so where information has been shared inappropriately, and what recourse do our businesses and or citizens have? And so I'd like to make sure that we have that really tightened as we move forward to ensure that there are significant definitions or really well-defined definitions of what is proprietary information from the provider of the pharmacy networks. So
Senator
just a
Jensen.
comment. Thank you.
Thank you, Mr. Chair, and thank you, Senator Cran. I would like to ask a couple testifiers to make comments on this, but I would say this. This is that tricky tension part where we're trying to be transparent and yet we're trying to be respectful of proprietary information. It allows a company to do the things it needs to do, one of which is to bid and decide which products are going to go on the formulary. You can imagine how difficult it would be for them to do any kind of cost constraints if they were having to advertise everything. So I think we're very close. I think we're going to continue to do a little bit more work, and whether or not that final result comes before or after the floor, I think conference committee will be an opportunity. We know that the bill moving along in the House is not a carbon copy. It has some differences and obviously many, many similarities. I would have no other comments, but I think testifiers might like to.
Mr. Chair, quick follow-up.
Testifiers that would like to respond? Mr. Root.
Thank you, Mr. Chairman and members. We too share your skepticism, not necessarily of your Commerce Department, but just generally of being careful about the information. That was the nature of many of our discussions with Senator Jensen, and also was the nature of some amendments to that section of the bill that we have only recently, within hours, provided to Senator Jensen for his review, and we will continue to discuss. Again, it's striking that balance between we like to think of it this way: there's good transparency and there's bad transparency. Transparency that raises costs is bad transparency. Transparency that provides consumers and health plans and those people in the supply chain with information to make quality purchasing decisions is considered good transparency, and we have to make sure that we balance the two.
Other testers that would like to respond to that question? Seeing none, Senator Cran, follow up.
Thank you, Mr. Chair. Along those lines, when we talk about reporting to the Department of Commerce as it's defined in the bill, am I to assume it's only for products sold in Minnesota, or would it require national reporting? Products that are sold nationally.
Thank you, Mr. Chair. Thank you, Senator Cran. I'm going to defer to Mr. Root.
We would take the position that the only aspect that the legislature has authority over would be those health plans licensed to do business in the state of Minnesota and the information that pertain to them.
Thank you, Mr.
Senator
Chair.
Cran, follow up.
Thank you. Nope,
Senator
thank
Hausel.
Mr. Chair,
Senator Jensen.
if I could have one quick comment to
Yes.
that. I do think that there might be a little bit of a different perspective than Mr. Root's from my perspective in terms of if medicines are going out at this price in Iowa and Wisconsin. I may need to know that information to make certain that we're hitting that balance in terms of transparency.
Mr. Schondelmeyer.
Yes, Mr. Chair. We need to carefully consider kind of the geographic scope. I understand not reaching beyond what Minnesota is relevant in Minnesota. But for example, at the university, as a plan sponsor, we pay for prescriptions in all 50 states that come from pharmacies and or PBMs and or specialty pharmacies or mail order pharmacies in all 50 states. So just because we're in Minnesota doesn't mean we only buy drugs in Minnesota. And we pay for health care in all 50 states. So to some degree, we need to look at and make sure we have a reach to cover areas where Minnesota sponsors are paying for drugs that come into the state from elsewhere.
Mr. Root.
If I may, for just a moment, and perhaps my comment was misconstrued, what we were talking about is the fact that it would not be, we do not read the language as looking to require us to provide you with our rebates for our entire book of business. In other words, we are not going to show the Minnesota Commissioner the rebate arrangements that we have with Kansas Blue Cross Blue Shield. So to Mr. Schondelmeyer's example, everything associated with the Minnesota university system is part of our Minnesota book of business. So you would have that information would be part of what we contain. Are we going to provide, again, the state of Minnesota, the arrangement that we have with Nebraska Blue or Kansas Blue? No, that's not correct, because we don't believe that you have the purview to ask for that.
Senator Housley.
Thank you, Mr. Chair, and Senator Jensen for bringing this bill forward. It was a topic that came up all summer long around the state, is PBMs. But for Mr. Schondelmeyer, if I could, what is the relationship with generics and rebates? How does that work, or do they also do the rebate?
Mr. Schondelmeyer.
Thank you, Mr. Chair, and thank you, Madam Senator. Another very good question without a simple answer. In general, generics don't have rebates like the brand names do, but there are times when there are rebates around generics. But in this case, the PBM usually doesn't put brand or company A's generic on the formulary and knock company B, C, and D off the formulary. So they don't often steer the generic that we use. What they will do is they'll tell the pharmacy, Ms. A-Strip's pharmacy, we won't pay more than 37 cents for a tablet of that kind. You can buy it from any of the 6 generic companies you want, but we won't pay more than 37 cents. Although they won't give that pharmacy a list of the MAC prices that she will be limited to. She can call and ask for them or look them up one at a time, but they don't tell her kind of the terms of business straightforward. So generics sometimes have rebates, but it's a totally different game than we see on the brand name side of the business. There are issues around it, but they're different issues. Keep in mind, generics account for 85% of all prescriptions filled, but only about 20% of the dollars we spend because they're so much cheaper to begin with. So the money is on the brand name side. There are a few issues around generics and rebates, but they're different kinds of issues.
Senator Housley, follow up? Members, any other members that have any questions for the testifiers or Senator Jensen? Seeing none, Senator Utke renews his motion to pass Senate File 278 as amended with recommendation to pass it go to the Finance Committee. All those in favor signify by saying aye. Aye. Opposed, nay. The motion carries. Members, this concludes our business for the day. The Commerce Committee is adjourned.